they start misbehaving. These bean-shaped structures are capable of breaking our heart and brain. There's one person who knows exactly how to discipline them, and let's look forward to his talk. It will now be the turn of Dr. M. Gopinath sir and Dr. N. Yohishwaran sir to chair this session. We welcome you both onto the dais, sir. Dr. Gopinath sir was graduated from Tanjavur Medical College and finished his MS General Surgery from Government Medical College, Hubli. He also obtained his DNB General Surgery degree and completed his MCH Urology from Madras Medical College. Dr. N. Yohishwaran sir did his MBBS from MS Ramaya Medical College, Bangalore and DNB General Surgery from Father Muller Medical College, Mangalore. He is currently working at Dr. K.M. Nallaswamy Hospital, Erode. I welcome Dr. M. Gopinath sir, Dr. N. Yohishwaran sir to introduce and welcome our next speaker, Dr. V. Nagendran sir.
Good evening, everybody. Glad to welcome Dr. Nagendran, young enthusiastic nephrologist and a colleague of mine at Sudha Hospital. Dr. Nagendran did his MBBS in PSG Medical College, Coimbatore, followed by General Medicine in KMC Mangalore and DM Nephrology in Government Kilpak Medical College, Chennai. His area of interest are renal transplantation and CAPD. Dr. Nagendran is instrumental in starting the renal transplantation program in our Sudha Hospital. Over to Dr. Nagendran, please.
Good evening to everyone. Today first of all, thanks for Sudha Hospital management for giving me this opportunity to speak. My topic is acute kidney injury and renal replacement therapy. Here, what is acute kidney injury? First, acute kidney injury is defined as a creatinine jump of 0.3 milligram from the baseline within 48 hours, or creatinine increase to 1.5 times from the baseline, which is presumed to occur within 7 days, and decrease in volume output 0.5 ml per kg per hour for more than 12 hours. That is defined as acute kidney injury. And staging of acute kidney injury, the AKI is common, harmful and has a high mortality rate, and incidence varies between 50% to 80% in ICU setting. And staging of AKA is depend on two main classification, Akin and Rifles, that both the classification depend on two criteria only. One is creatinine and another one is urine output. Based on this only they have classified and staged the acute kidney injury. And whenever possible, the cause of AKA should be diagnosed, and it will help in the management. And mortality rate increase up to 2 to 3 folds when compared with AKA in ICU without AKA. Next, staging. Staging depend on two urine output. One is Akin criteria. Next one is the Rifles criteria. Urine output is common. Stage 1, 0.5 ml per kg per hour, less than 6 hours, more than 6 hours. Less than 0.5 ml per kg per hour for more than 12 hours is stage 2. 0.3 ml per kg per hour or for more than 24 hours, or anuria for more than 12 hours, in stage 3. In both Akins where creatinine is used, stage 1 1.5 to 2 times, stage 2 more than 2 times, stage 3 more than 3 folds, an increase in creatinine of more than 4, or RRT requirement, dialysis requirement. This is defined as Akin. Rifles, the same criteria where GFR has been increased. In stage 1 where less than 25 ml, injury less than 30, failure less than 25 ml. Previous concept where increased risk, damage, GFR, kidney failure, death. Now the concept has been changed in 2022, where fall in GFR that lead to tubular injury that will progress, pathological outcome either resolution or it can be fibrosis. Clinical outcome of AKA, if you see, full recovery can be there, subclinical renal scarring can be there, or chronic kidney, it can acute kidney injury leading into chronic kidney disease and end-stage renal disease requiring dialysis, permanent dialysis. Causes, if you see, basically it's three. Kidney can be divided into three: pre-renal, renal, and post-renal. Pre-renal, most common is dehydration, bleeding, hypoglycemia, cardiogenic shock, and cirrhosis of liver. Renal, most common is drug, NSAID, and antibiotics like aminoglycoside, vancomycin, amphotericin B, and other drugs. Contrast-induced injuries and sepsis. Acute interstitial nephritis, TMA, acute glomerulonephritis, and renal artery stenosis. And finally, the post-renal papillary necrosis and tumor. And before going, we should know who are the susceptible and what are the exposures. Exposure, if the patient is exposed, is having sepsis, critical illness, cardiogenic shock, burns, trauma, major cardiac surgeries, and nephrotoxic drug, contrast has been used, and poisoning, all this has been exposure that patients are at the risk. And who are susceptible individuals? The patient is dehydrated, advanced age, female gender, black, chronic kidney disease like heart, lung, liver, diabetes, cancer, and anemia. All these patients are susceptible to kidney disease. Management of AKA, it's very simple. We have to find out high-risk individuals and discontinue all the nephrotoxic drugs. That is the first thing. And we should ensure the volume test and hemodynamic monitoring, perfusion pressure, and continuous monitoring of creatinine and urine output has to be there. And if possible, avoid contrast, IV contrast for CT. And if staging has been started, we can go for non-invasive followed by invasive. In stage 2, definite change in the drug dosing has to be followed. Change in the drug dosing has to be followed, and considered RRT at stage 2 and ICU admission. And final, if we are planned to start on RRT, that is dialysis, definitely subclavian should be a last option. General management, in AKI management, first thing is cause. Find out the cause and treat the cause. Next is fluid management. If shock is there, isotonic, shock or no shock, anything, isotonic crystalloid is preferable. In safe study, whether albumin has a role, albumin with saline or individual albumin itself or saline only, there is no major difference. Albumin usage doesn't have any added advantage. Hydroxyethyl starch, if AK is there, better to avoid. And colloids, that is albumin on other colloids, has definite value in certain cases like burns, cirrhosis, and if you want to avoid excess fluid, we can administer albumin. And whether isotonic crystalloid or buffered salt solution can be used to avoid hyperchloremic acidosis. And in vasomotor shock with the fluid, vasopressors also can be used. All the vasopressors as equally effective. That in kidney point of view, I am saying non-adrenaline usage, vasopressin or dopamine or dobutamine doesn't have any role in increasing output or saving a kidney. And in new intensive care narrative review, they have shown the vasopressin has got better kidney outcome in the form of output and creatinine reduction. Vasopressin is the first option. Next is non-adrenaline. Next is dopamine. And in all the general management, we have to keep MAP above 65, CVP 8 to 12, and decrease the blood lactate level and central venous oxygen level to keep more than 70%. And glycemic control, target around 110 to 250, and energy intake, total energy intake 20 to 30. Protein intake, definitely 1.8 to 1 gram. If we are planning for RRT, protein intake has to be increased. 1 to 1.5 grams per kg per day. If hypercatabolic rate patient, 1.7 grams per kg per day can be used. And definitely to avoid protein restriction, especially if we should avoid the restriction of protein in aim to prevent or delay the RRT. Diuretics, whether it has a role. Diuretics, definite benefits are there. It decreases the oxygen consumption in thick ascending lobe, and it wash out the necrotic debris, and it inhibits prostaglandin dehydrogenase. Whether this benefit convert into clinical effect on mortality and RRT, it is doubtful. In the case of hyperkalemia and volume overload, we can use the diuretics, and KDICO doesn't recommend to use diuretic to prevent AKA. Any pharmacological, to date, no specific drug is available to prevent or to treat AKA. The role of dopamine, phenodopamine, NNP, NAC, no role. And whether now human recombinant alkaline phosphatase, the newer drug, initial few days it reduce the creatinine and increase the uric output. At the end of the 1 month, it doesn't have any major role. Now coming into next part, that is renal replacement therapy. What is renal replacement therapy? Here we will see what is the application of renal replacement therapy. Initiation, whether early, late, very late. What is the modalities? What is the choice? And when to stop RRT. Potential application, that is life-threatening applications. All we know, hyperkalemia, acidemia, pulmonary edema, and uremic pericarditis and bleeding. These are all definite life-threatening indications. Non-emergency, that is solute control, fluid removal, and correction of acid bed. In non-emergent, renal support, where we need a volume control, where we need to administer nutrition, where drug delivery has to be there. So, solute modulation, especially in tumor lysis syndromes, where these are the indications for RRT initiation. Early versus late. When to initiate RRT? Here, the landmark trials, some trials are there. One is Ellen trial 2017 and Akiki trial in 2016. Ellen trial they conducted in Germany. That is basically a post-op ICU care, where most of them will be surgical patients, where the early and late they divided. Early stage, where according to KDICO guidelines, stage 2, if the patient comes in, they will initiate within 8 hours. Late KDICO guidelines, stage 3, 12 hours, within the 12 hours they will initiate. If you see the mortality at the end of 90th day, the mortality difference is little higher in late initiation. So secondary outcome also, it is better for early initiation. In Ellen's trial, early initiation they advise in stage 2. Whereas Akiki trial 2016 they conducted in France, that is a multicentric trial where 39 ICUs has been included. Totally 600 patients has been included, where the early initiation within 6 hours, where late initiation oliguria and anuria lasting more than 3 days, that is 72 hours. And they see mortality at the end of 60th day, there is not much difference. And if you see secondary outcome, SOFA score, duration of RRT and vasopressin bleeding risk, it is also not major. So earlier is equal to late. There is not much difference in here. At a bottom line, what they are coming to say is the critically ill patient, early initiation doesn't provide any mortality benefit when compared to delay. And in late initiation, 50% of the patients, they deferred a dialysis. And there is a significant high rate of catheter-related nosocomial infection is there. And there comes a new trial, Akiki 2 trial, where in 2021 they have conducted, where they compared delay with more delay. Delay here is stage 3, more delay is certain criteria they have taken. One is if the patient is having pulmonary edema, hyperkalemia of around 6, metabolic acidosis of more than less than 7.15, with all these criteria, more delay. Here, the concluded, if longer the postponing of RRT initiation doesn't have any additional benefit, but associated with the potential harm. So, at the end, this is a latest trial. It is a meta-analysis report, where in European study, there they have around 800 papers they have screened, and 13 randomized RCT has been selected. 5,000 patients has been chosen. Early versus late. We have seen the reported at 28 days mortality. Early initiation of RRT doesn't improve mortality, nor it likely to recover the kidney function or increase risk of, they have increased risk of RRT associated injury. Finally, what they conclusion is, timing of initiation is uncertain. Early initiation, not much beneficial. Very late initiation is harmful. So, initiation better in stage 3. KDICO guidelines, stage 3 will be a better option. Access. Here, vascular access, first option will be right AJV. Second option will be left. Third will be left femoral. Fourth will be right femoral. Last option will be subclavian. And all of them should be ultrasound guided, and chest X-ray should be taken after each. Modality of RRT. What we see from your left side, all are CRRT. That is slow, low efficacy. Where if you see blood flow will be very low, 100, 200 it will be. Where you see in the right, intermittent hemodialysis, the flow will be high, faster will be the removal. And if you see the predominant solute transport, the diffusion will be the method. And IHD, that is what we commonly use, intermittent hemodialysis. It is indication in a stable hemodynamically patient. What is the advantage? Rapid removal will be there, reduced anticoagulation usage, lower cost. Disadvantage, hypotension and DDS will be the disadvantages. CRRT in an unstable patient, in a patient with head injury, especially with the intracranial pressure increase is there, we can use. Advantages, there will be continuous removal, hemodynamic stability will be maintained, easy control, user-friendly machines. Disadvantages, slower removal, prolonged anticoagulation, immobilization, hypothermia, the cost will be very high. SLED is slow, low efficacy dialysis, where in unstable patient we can use with whatever the machine we have. Here, the advantage is hemodynamic stability can be maintained, but disadvantages, slow removal of clearance will be there. PD, in an unstable, coagulopathy difficulty is there, difficult access is there, all this condition we can use. Advantage, it is very simple, stable, no access required, no anticoagulation, very low cost. Total cost of the treatment will be less than 5,000 rupees. Disadvantages, the predictability, unpredictability in solute as well as fluid removal, hyperglycemia, the risk of peritonitis, and it will remove the protein loss will be very high. In clinical scenario, the life-threatening complication is there, preferred intermittent hemodialysis, what we commonly use, followed by SLED, followed by RRT, last option will be PD. Fluid overload, if it is not an emergency, CRRT, IHT, then PD. Hemodynamic instability, definitely CRRT will have a role, followed by PD, then intermittent hemodialysis. Acute brain injury, intracranial hypertension, CRRT is the first option, then SLED, then intermittent hemodialysis. Hypercatabolic state, intermittent hemodialysis, then PD. When to stop RRT? Stopping RRT will happen only in 10%. And what is the when to stop? Exactly urine creatinine clearance, if it's more than 15 ml per minute, that definitely I'm not using. In other words, urine output seem to be an important predictor. And successful termination of RRT, if you stop the dialysis for 14 days, previous dialysis, then we can say it's successful stopping. There is no diuretic used to enhance the kidney function recovery or reduce the duration or frequency. Take home message, AK is a common with a high mortality rate in ICU. Early diagnosis and staging has a prognostic value. No specific drug is available for cure. And RRT is only a supportive treatment. The choice of modality is a physician choice, which form we have to take. Thanks.
Thank you, sir. That was an amazing presentation.
Thank you, Nagendran, for the presentation. Do you have any cutoff level regarding the creatinine? Because there are some patients do not have volume overload and they produce enough urine, but the creatinine levels keep rising. Do you have any cutoff level where you start inducting them into RRT?
So basically, there is no cutoff value because creatinine is not, creatinine doesn't indicate only kidney disease. Creatinine comes from a muscle, other factors are nutrition, other factors are there. Based on creatinine only we can't define, but generally in pediatric age group, if creatinine is more than 4, we can take. And whatever in acute setting, it is basically a clinical determination. If clinical indication is there, definitely we have to take.
Okay.
Based on creatinine, we can wait up to. But early initiation doesn't have any added advantage. Very late, leaving very late is also will do harmful. In between the KDICO guidelines, according to KDICO stage 3, if patient comes in, he should think about starting RRT. But there is no definite cutoff line of 4, 5, 6. There is no cutoff line. Pediatric 4 is there. But
Thank you.
Thank you, sir. Being alive is about playing to win. Being brain dead is when you play not to lose. With increasing awareness, the last decade has shown significant progress in organ donation, not only from living donors, but also from brain dead. So it's the need of the hour for ourselves to get updated in the management of brain dead organ donor. I invite Dr. N. Yohishwaran sir to introduce and welcome our beloved last speaker of this session, Dr. P. Nithyanandan sir.
Good evening, everybody. On the offset, I would like to thank the Society of Anesthesiologists of Erode branch and Sudha Multispecialty Hospital to conduct this critical care program. And I would like to welcome Dr. Nithyanandan.
Thank you, sir.
Dr. Nithyanandan is a consultant cardiothoracic anesthetist of the Sudha Hospital, Erode. He completed his MBBS in Thanjavur Medical College, did his MD anesthesia from Ram Manohar Lokia Hospital, New Delhi, and then he specialized, super specialization of DM cardiothoracic anesthetist in Chitra Renal, Trivandrum. To his credit, he has published more than 10 publications in international and national journals. He's awarded, he's won first prize in quiz competition in ISA Delhi Annual Conference, and he was JHA Award nominee in 2015, Tamil Nadu chapter. Again, quiz competition winner in ISA Delhi Annual Conference 2016. Dr. Kobes Award medalist Isakon Jaipur 2016. First prize in echocardiography quiz, National Echocardiography Conference, PGI Chandigarh 2020. I think list keeps on going. Anyway.
Thank you so much for the kind introduction. Okay. Positivity is the only way ahead. Let's start positively. Brain dead patient, only positive thing in brain dead is that their organs can be harvested. In the next few slides, I'm going to talk about what is brain dead and what are the organs we can preserve and what are the monitoring techniques we need to preserve the organs and management during organ procurement and donation about circulatory death. First, defining brain dead, the patient should be normothermic. Core temperature should be more than 36 degrees Celsius. And systolic blood pressure should be more than 100 millimeter of mercury, with or without support. And there should not be any drugs that causing brain death, like mimicking symptoms, like neuromuscular blocking agents, drug intoxication, or blood alcohol content should be less than 0.08%. And all the brainstem refluxes should be absent. And apnea test should be positive. There should not be any respiration after PCO of more than 60 millimeter of mercury. Organ donation over the years have evolved and saved or enhanced lives of hundreds of thousands of recipients worldwide over the last 50 years. Optimal donor management is essential to both in intensive care setting and operating room to maximize the function of transplanted organs and quality of life and survival benefit. In monitoring, before organ procusion, hemodynamic and respiratory monitoring is most important. Hemodynamics, you have to monitor heart rate, rhythm, and blood pressure, pulse oximetry, respiration, airway process, temperature, urine output. Invasive arterial line is very important to check for fluid responsiveness like pulse pressure variation and stroke volume variation, and for drawing blood samples. And central venous pressure monitoring is important to check for central venous pressure and mixed venous oxygen saturation, and for transmission of IV fluids and vasopressor and inotropic agents. Laboratory monitoring includes monitoring renal function tests, liver function tests, lactate levels. Pulmonary artery catheter in selective patients for calculating cardiac output, stroke volume. Bacterial culture should be taken from blood, urine and sputum before procuring the organ for transplantation. Upper and lower airway testing for patients undergoing lung transplant. What is the optimum blood pressure goal? Target mean arterial pressure is about 60 to 100 millimeter of mercury. In prices, it is 60 to 65 millimeter of mercury. Then what is hypertensive autonomic shock? As soon as patient is declared brain dead, initial sympathetic discharge happens and causes autonomic surge followed by hypertension, tachycardia and increased myocardial oxygen consumption. If at all we want to treat this, we have to use short-acting agents like beta blockers, esmolol to counteract this, because this episode is followed rapidly by hypotension. Hypotension could be because of either hypovolemia or reduced myocardial function or because of vasodilatation. Choice of fluids. Which fluid can be given for patient undergoing transplant? If the patient shows hyperchloremic acidosis, go for ringer lactate or any bicarbonate containing solution. Whereas if the patient is hyponatremic, go for hypotonic solution. Target sodium is less than 155 milliequivalents per deciliter. On target potassium is 4 to 5 milliequivalent per deciliter. Regarding colloids, albumin is preferred compared to hydroxyethyl starch because of the renal toxicity. Regarding transfusion trigger, hemoglobin less than 7 is 11 means we have to transfuse blood products. Okay, we given the fluids and blood products, patient is still hypotensive, then we have to think about vasopressors. Vasopressor of choice is vasopressin. Even after administering vasopressin, patient showing vasodilatory shock, then go for dopamine as first choice of drug, followed by noradrenaline and phenylephrine. If the patient still showed hypotension, then we have to, on echo, we have to evaluate the myocardial function. If the ejection fraction is less than 45%, then we have to start dopamine, dobutamine or adrenaline. Kidney injury happens after brain death mainly because of anoxia. Normally this anoxia recovers itself in 24 to 48 hours. But diuretic refractory oliguria anuria leads to hyperkalemia, metabolic acidosis and volume overload. And these patients can be benefited for renal replacement therapy. In a study comparing renal replacement therapy with the blood medical management, they showed that patients who have received renal replacement therapy showed better graft survival. And ventilation and oxygenation, these are to prevent tissue hypoxia. And preferred ventilation mode is low tidal volume ventilation. And target peak and plateau airway pressures are peak pressures of less than 35 centimeter of water and plateau pressures of 25 centimeters of water. And we have to prevent ventilator-associated pneumonia with the help of head and elevation and appropriate antibiotics. And lowest FiO2 possible to maintain saturation above 94-95. And lung recruitment should be there because as soon as the patient is declared brain dead, there will be chance of basal atherosclerosis because of diaphragmatic immobility. As per organ procurement transplant network policy, lung donor blood gases are measured on FiO2 of 1%, 100% and PEEP of 5 centimeter of water, and PaO2 more than 300 millimeter of mercury is generally considered for lung transplantation. Other than this, think about prone ventilation. In a study comparing prone ventilation with supine ventilation, prone ventilation showed better organ survival and better PaO2. The nebulized albuterol is recommended only in patients who are having bronchoconstriction like in asthma. In patients who are having PaO2 by FiO2 less than 300, even after intensive lung donor management, ex vivo lung perfusion is preferred because it improves oxygenation and improves the pulmonary compliance. Hormonal therapy. Following brain death, the patient's metabolic and hormonal disturbance happens, and hormones we have to recommend are vasopressin or desmopressin, glucocorticoids, thyroid hormone and insulin. Vasopressin or desmopressin, because patients, as soon as brain becomes dead, there is brainstem herniation leading to compression of the pituitary, causing central diabetes insipidus, characterized by urine output of more than 1000 ml per hour, hypernatremia and hypotension. Vasopressin is given for patients who are having who need a vasopressor and central diabetes insipidus. Loading dose is 1 unit followed by infusion of 0.01 to 0.1 units per minute. Doses more than 0.04 units per minute have been assured with adverse outcome. Whereas desmopressin, it is an analog of vasopressin. It has a better antidiuretic effect and substantially less vasopressor effect. So for patients who are deceased donors with normotensive but with central diabetes insipidus, we prefer desmopressin. And the dose is 1 to 4 micrograms IV. A typical dose is 1 to 2 microgram IV 6 hourly. Glucocorticoids has its use in deceased donors because it acts as an anti-inflammatory for lung donors, and it counteracts adrenal insufficiency and for patients who are hypotensive in need of steroids. Methylprednisolone dose of 15 mg per kg, hydrocortisone 300 mg once, and then 100 mg 8th hourly is recommended. Thyroid hormone recommendations are inconsistent related to thyroid hormone injection. If at all we need to inject, we better go for levothyroxine instead of T4. Levothyroxine dose is 20 microgram IV bolus followed by infusion at 10 microgram per hour. Glycemic control, tight glycemic control is important, and target blood glucose should be 120 to 180 milligram per deciliter. Hyperglycemia causes osmotic diuresis and hypovolemia, so better to keep the glucose under control. Therapeutic hypothermia, following brain death because of hypothalamus dysfunction, patients become temperature dysregulated. So therapeutic hypothermia of 34 to 35 degrees Celsius produces better graft function after kidney transplant. Regarding venous thromboembolism prophylaxis, just like in all critical care patients, deceased donors also at high risk of venous thromboembolism, so prophylaxis should be given. In case of prophylaxis, go for medical prophylaxis compared to mechanical methods, and low molecular heparin, enoxaparin 40 mg every 12 hours is recommended in patients with good kidney function. For patient with kidney failure, go for unfractionated heparin. Successful prophylaxis can be given with pantoprazole, famotidine, and sucralfate. Empirical antibiotics depends on local antibiogram and based on the organ that is to be transplanted. In general, for lung transplant patients, go for gram-negative and MRC. Grief counseling is recommended for patients who lost their kids, or family members should be explained about the procurement procedure, anesthesia during procurement, and eventual transfer of the remains of loved ones to the funeral home. Next, we have to determine which organs will be retrieved. For lung donor, we have to check PaO2, PCO2 levels, and chest radiograph to look for any external lung injuries, bronchoscopic airway survey for invasive airway injuries, patient with known history of any lung disease and previous cardiothoracic surgery. For heart donor patients, we have to make sure that heart function should be adequate. It should be more than 55% ejection fraction. In case patient ejection fraction is less than 55%, go for serial echo assessment and make sure that patient is normovolemic. In contrast to broken heart syndrome, hypokinesia in this patient is basal and anterior wall compared to apical sparing, whereas in broken heart syndrome, Takotsubo cardiomyopathy, apical ballooning will happen. For liver donor, patient's age more than 50 or hepatic steatosis more than 30% or cold ischemia more than 12 hours, hypernatremia, hemodynamic instability are considered as a contraindication for liver transplant donor, or it shows negative results. For potential kidney donors, HLA antibody matching, type of kidney, whether live or donor age, donor disease, and center that is doing the procedure has to be taken into consideration. For pancreatic transplant, patient age more than 50 years or BMI more than 30, creatinine level more than 2.5 milligram per deciliter, or preservation time more than 20 hours also shows negative results. So better not to donate. So what are the things we have to do in the operating room? Till now we have seen the patient in intensive care. Now we have to switch to operating room. Make sure that all the monitoring are intact, ventilation should be continued, antibiotics should be prescribed, and adequate blood products should be available. Heparin, glucocorticoids should be discussed with the surgeon. For lung procurement, we have to upsize the tube, endotracheal tube. Then spinal reflexes. Although patient is declared brain dead, the spinal cord is still intact. So there may be unregulated sympathetic and motor spinal reflexes in response to stimulation. So to counteract the motor response, we have to use neuromuscular blocking agents. And to counteract sympathetic response, we have to use vasoactive drugs or inhale anesthetics like isoflurane and desflurane, if available. Temperature, forced air and fluid warming should be used intraoperatively to maintain a temperature of 35 to 37 degrees Celsius. Anticoagulation, heparin 300 units per kg or 3 mg per kg is recommended. In patients who are hemodynamically unstable, higher doses are recommended. As soon as achieve the adequate anticoagulation, iodized cross-clamp and transplantings will proceed with the procurement. Donation after circulatory death. Patient who does not meet neurological criteria for brain death but has no hope of viable recovery, like example stroke, cardiac arrest, or multiple trauma, those patients are declared as donation after circulatory death. Compared to role of ECMO, it is still in early stage and multiple studies are in stage to deliver a final thought. Thank you.
Thank you, Dr. Nithyanandan, for your wonderful talk. With increased awareness of organ donation, now we are getting calls every other day for organ donation. And of course, this topic will naturally enlighten all people regarding this. Thank you.
Thank you, sir.
Thank you, sir. It was indeed a great presentation. It'll be a great pleasure for us to listen to you again on our future events. Thank you once again. Now, I cordially invite our beloved chairman, Dr. Kandasamy sir, to felicitate and present mementos to our chairpersons and speakers. Thank you, sir.